Good afternoon. Welcome to today's webcast entitled Antenatal Corticosteroids in 2012, What Clinicians Need to Know, presented by Dr. Shailen Shah, Medical Director of Maternal Fetal Medicine, Virtua Maternal Fetal Medicine Center, Voorhees, New Jersey. Following the talk, we'll have a short question and answer session. You can submit questions at any time during the presentation via the web using your Ask a Question box. If you should need technical assistance, type your inquiry into the tech support box on the left side of your screen and click the Send button. If you are disconnected, you can log on again using the instructions provided to you for accessing this webcast. If you cannot log back on, please call 877-843-9272. That number again is 877-843-9272. It is now my pleasure to turn the webcast speaker, Dr. Shah.
Hello everyone. On behalf of Hologic, I'd like to thank you for joining us for this mini course. The objectives of today's talk are the role of antenatal corticosteroids in the management of preterm birth, current guidelines for use, when it may be appropriate to repeat a course of steroids, appropriate spacing, 12 hours versus 24-hour dosing, and finally, efficacy before the traditional 24-week window and after 34 gestational weeks. Before getting into the talk, I need to point out that I'm a paid consultant for the contents of this webinar, as well as on the Speakers Bureau for Hologic regarding fetal fibronectin. So my product is a sponsored product, but I can tell you that I solely came up with the contents of this talk and mimics what I use in clinical practice. Before we get into the talk, I felt it would be appropriate to ask some polling questions to tee up our conversation. The first question is, and I'd like you to answer it using your screen, is it appropriate or desirable to dose the second dose of steroids in 12 hours instead of 24 hours when preterm delivery is felt to be likely prior to 24 hours? The choices are yes, no, I don't know. And we have approximately two-thirds of the respondents saying yes, about 30% saying no, and about 12-14% saying I don't know. Are antenatal steroids beneficial prior to 24 weeks? Once again, yes, no, I don't know. So as the respondents come in, it looks about three-fourths yes, and about 30-40% no. The final question: should antenatal steroids be repeated every 2 weeks until 34 weeks in pregnancies remaining at ongoing risk for preterm birth? This one, yes, no, I don't know for a final time. Seems like everybody is responding. We have 50% yes, 50% no, and a few respondents saying I don't know. Well, thank you for answering that. We're going to revisit these questions and answers at the end of the talk. Well, this audience certainly understands that preterm birth is the leading cause of neonatal mortality and a major cause of neonatal morbidity. In fact, 70% of all neonatal deaths, 36% of all infant deaths, and 25 to 50% of long-term neurological impairment in children are due to preterm birth. In fact, it's the most common reason for antenatal hospitalization. In the United States, 1 out of 8, or 12% of all live births, occur prior to term. In 2012, it's reasonable to think of this in medical economic costs, and it's estimated that it costs the United States approximately $26 billion per year to treat preterm birth, meaning that it's about $51,000 per every premature infant. A big problem, clearly. Management has focused really on two strategies: prevention and changing neonatal outcomes. On the left-hand side, you'll see the traditional prevention management schema: bed rest, pelvic rest, hydration, antibiotics, tocolytics, and most recently progesterone. On the right, you'll see improving neonatal outcomes. We're left with two: antenatal corticosteroids, what this talk is devoted to, and magnesium sulfate for neuroprotection. Administration of steroids to women at risk for preterm birth is strongly and consistently associated with decreased neonatal morbidity and mortality. In fact, of all our intervention strategies, it is the most beneficial for improvement of neonatal outcomes among women who give preterm birth. You can see from this slide, which is a summary based on the Cochrane database of the effects of antenatal corticosteroids, that corticosteroids decrease neonatal death by 30%. It decreases respiratory distress syndrome by 35%. It decreases intraventricular and cerebroventricular hemorrhage by 50%, necrotizing enterocolitis by 55%, overall NICU admissions by 20%, and early systemic infections by 50%, a substantial benefit to babies born prematurely. The glucocorticoids betamethasone and dexamethasone are the most widely studied and therefore the preferred ones. They cross their placenta in their active form. They're chemically identical with the exception of a single methyl group, and so they have nearly identical biological activity. The single methyl group difference allows betamethasone to have a longer half-life. The question often arises if one is superior to the other. In 2000, the NIH consensus panel reviewed the safety and efficacy reports that were available at the time and found no significant evidence to support one over the other. In 2008, a Cochrane database review of 10 trials showed no difference of one over the other in terms of perinatal death, but did show a decrease in intraventricular hemorrhage rate with dexamethasone. On the other hand, in the same year, in a different journal, there was a study published that showed less adverse neurological outcome with betamethasone. The bottom line is the data is inconsistent and limited and insufficient to recommend one over the other. The current American College of ObGyn guidelines recommends that a single course is given to pregnant women between 24 and 34 weeks who are at risk for preterm delivery within 7 days. The benefit is also seen in women with premature rupture of membranes prior to 32 weeks. The benefit in this setting between 32 and 34 weeks is less clear, but probably beneficial, and clinically it is usually administered. A Cochrane database of this reinforced this mantra by showing that the benefit effect of this therapy is present regardless of membrane status, and concluded that a single course of antenatal corticosteroids should be considered routine for all preterm deliveries. This slide demonstrates the dosing. Betamethasone is on the left and the dose is 12 milligrams. Dexamethasone is on the right and the dose is 6 milligrams. Because betamethasone has a different half-life based on that methyl group, it's repeated for a total of 2 doses in 24 hours. Dexamethasone is given every 12 hours for a total of 4 doses. Having stated the current standard of care with steroids, there are certain questions to consider in the second half of our talk that are clinically relevant on a day-to-day basis on the floor. Should I dose less than 24 hours? Should I give a repeat course of steroids? Should I ever use steroids before the traditional 24 weeks? And on the other hand, should I ever give steroids after 34 weeks? Let's talk about these questions. When is it appropriate to repeat a course of steroids? Many women treated for preterm labor will remain pregnant despite our best efforts at predicting accurately who will deliver early for more than 1 to 2 weeks after they've been given treatment. The duration of steroid benefit is controversial, but the original data suggested that the benefit to the baby waned after 7 days. Furthermore, steroids have been seen to be very safe. There's no convincing evidence that it increases the risk of neonatal infection, and even long-term studies of adolescents exposed to antenatal corticosteroids show no adverse neurodevelopmental outcome. This combination of safety and the fact that it wears off after 7 days led to weekly or every other week doses in women who remained at risk for preterm birth, so-called repetitive dosing. But truly, this was done on extrapolation of data and with no establishment that it was safe. Basic science data suggested deleterious effects regarding brain architecture, lung growth, and adrenal axis function of repeat exposure to steroids. Then, between 1999 and 2008, there were at least 7 trials that examined the effects of repetitive steroids, and they showed complications. Most of them showed decreased birth weight and head circumference, and as a consequence of all this, there was a moratorium on repetitive dosing. I would draw your attention to the Wapner trial of 2006, which randomized single versus multiple dosing, and they showed a reduced birth weight and increased incidence of small for gestational age infants after 4 or more doses. So, while there was a moratorium on repetitive dosing, there remained a clinical interest in a single repeat, so-called rescue steroids for women who remained at risk for preterm birth and remained pregnant. This question was attempted to be answered by Tom Garidi, who did a study in 2009. They took women who had a recurring threat of preterm birth less than 33 weeks, without premature rupture of membranes, who had completed a single prior course of antenatal corticosteroids earlier than 30 weeks, and at least 14 days prior to enrollment. Those patients who met this criteria were randomized to a single rescue course or placebo, and ultimately they enrolled 437 patients. And what they demonstrated was less respiratory distress syndrome, less need for surfactant, and less composite neonatal morbidity with the rescue course, and at no expense of increase in newborn complication or IUGR. They concluded that a rescue dose was beneficial. This was echoed in a Cochrane meta-analysis of other studies and published in 2011 that showed a single rescue dose at least 7 days after the initial course and less than 34 weeks showed a benefit to the patient. So these observations, along with its safety when given in a less repetitive fashion, led to ACOG endorsing a rescue dose in their 2011 committee opinion. They indicated that a single antenatal corticosteroid dose could be repeated as a rescue dose if the antecedent course was given at least 2 weeks prior and the woman was less than 33 weeks, and importantly, that the woman was judged by her clinician to be likely to deliver within the next week. They certainly didn't want a rescue dose prescribed on just a scheduled basis unless there was an ongoing risk for preterm birth, and they reiterated that repetitive doses were not recommended. So we're left with the clinical issue that we have only 1 or at the most 2, when you count the rescue dose, steroids to give a patient. And so timing it appropriate to their risk of preterm delivery becomes paramount. One way to do so is to use preterm delivery predictor tools such as cervical length or fetal fibronectin testing. This slide highlights fetal fibronectin testing in the setting of symptomatic preterm labor. That is to say, the patient who comes in with mild cervical dilatation and symptomatic preterm contractions. A negative fetal fibronectin test in this setting has an incredibly strong negative predictive value. In fact, the chance of delivering after a negative test despite symptoms within 1 week is less than a percentage point, within 2 weeks is less than a percentage point. And therefore, by my view, this allows us to identify the patient who would benefit from not getting steroids and avoiding unnecessary steroids to save them for a later date when they're truly necessary. In addition to this study, two other studies corroborated the highly negative predictive value of a negative fetal fibronectin. On the other hand, in the same setting, a positive fetal fibronectin predicts an increased risk of preterm birth. Within 7 days of almost 13%, within 14 days of almost 17%. By no means a robust number, but more enriched than just treating patients with a negative fetal fibronectin. This slide from the British Medical Journal highlights a concept known as number needed to treat. That is to say, how many mother-baby pairs do you need to expose to steroids to prevent 1 case of respiratory distress syndrome? An appropriate question when considering the pros and cons. In the triangle, you will see in the middle the traditional paradigm. That is to say, dosing steroids based on clinical prediction of preterm birth. And you can see that 109 mother-baby pairs would have to be exposed to steroids to prevent 1 case of respiratory distress syndrome. Not an unreasonable number. If you think about it, when we do Down syndrome screening, if you had a positive screen at 1 in 100 risk for Downs, that would allow you to offer a diagnostic test. On the other hand, if you limit preterm birth screening, steroids to those who test positive for fetal fibronectin, you only have to expose 17 mother-baby pairs to prevent 1 case of respiratory distress syndrome, a more robust treatment ratio. If you ignore your fetal fibronectin testing and treat with steroids despite negative fetal fibronectin, you'd have to expose 509 mother-baby pairs to prevent one case of respiratory distress syndrome. I can accept 1 in 100. I prefer 1 in 17. To me, the risk-benefit ratio does not justify 1 in 500. Clinically, for me and my group, this translates to the following protocol of giving steroids. We're more liberal with the first steroids because often the patient will present early in the preterm period, often before 28 weeks, when we have the most to lose with a preterm baby, as this audience understands, and therefore we have the most to gain with steroids. We're more strict with the second course of steroids if the woman remains at risk and pregnant because of the fact that we realize that's our last course. For a first set of steroids, if a woman presents at less than 34 weeks in our hands, and she has preterm labor less than 2 centimeters dilated and a positive fetal fibronectin, or a short cervix and a positive fetal fibronectin, or obvious preterm labor more than 3 centimeters dilated, they would qualify for the first set of steroids because that represents a high-risk group for preterm delivery. Despite that, many of them will remain pregnant but gain additional risk factors for preterm birth. For us, if they've gone at least 2 weeks and are less than 33 weeks, and if they present with advanced preterm labor, that is to say symptoms and cervix of 2 or more centimeters dilatation, we would consider giving a single rescue course. What about dosing interval? Sometimes the clinician is faced with the dilemma that they don't think the patient will last more than 24 hours pregnant in order to fully dose the course of steroids. And this has prompted the change of the 24-hour dosing to a 12-hour dosing with the intent of getting both shots in before the patient delivers. What I would point out is that while the optimal benefit of steroids takes 24 hours, there is benefit seen with even one shot less than 24 hours. And so the first dose should never be withheld, even if the ability to give second dose is unlikely. Secondly, there's been no demonstrated benefit of 12-hour dosing over 24-hour dosing, and therefore, even when preterm delivery is felt to be imminent, accelerated dosing should not be utilized. Are steroids effective, or should they be considered before 24 weeks? The original paper, the Ligands article, that examined the 24 to 34 week window picked 24 weeks because that was clinically relevant as age of viability for human pregnancy back then. Today, with advancements in neonatal care, neonates born at 23 weeks are surviving better than ever previously thought or expected. And Charlie Lockwood does a great job in his 2006 editorial in Contemporary ObsGyn arguing that the 23 weeks is the new 24 in terms of obstetrical management. However, the data about the efficacy of antenatal corticosteroids less than 24 weeks is sparse. 2 meta-analyses have questioned the efficacy even less than 26 weeks. And this led ACOG in 2011 to say and conclude that the use before 24 weeks could not be recommended. I think in 2012, this question needs to have critical examination. There were 2 studies that help guide our thoughts on this. One on the left-hand side is by Carlo and Jama in 2011. The other on the right-hand side by Kaiser and Obstetrics and Gynecology in 2012 shed some light in this question. On the left-hand side, the 2011 study, this was a prospective study of over 10,000 infants born between 22 and 25 weeks at 23 academic perinatal centers, an extremely robust and strong study. What they showed is that exposure to steroids, even at this early gestational age, significantly decreased death and neurodevelopmental impairment. In fact, at 23 weeks with steroids, that risk was 83% versus 90% without. 24 weeks was 68% versus 80%, and 25 weeks was 52% versus 67%. This was further corroborated in the 2012 study on the right-hand side. This group looked at infants born between 22 and 25 weeks that were exposed to steroids, and they had 237 such cases. They compared survival in this scenario versus historical expected survival without steroids. And what they showed was that steroids significantly improved survival. In fact, at 22 weeks, survival was 33% with steroids versus 19% without. 23 weeks was 58% versus 38%. 24 weeks was 87% versus 58%. And finally, at 25 weeks was 85% versus 70%. In my view, these two studies corroborate the intention that if obstetrically you're considering viability at 23 weeks in terms of your management, it is appropriate to give steroids for those women who are threatening to deliver prematurely. Another clinically relevant question is there a role for antenatal clinical steroids after 34 weeks? This is particularly true now when the rate of medical delivery for late preterm births is increasing. Why? Our population is aging, and with that, so is chronic hypertension, diabetes, and other indications for late indicated preterm birth. That is to say, between 34 and 37 weeks. Clinicians have often given steroids, bolstered by basic science evidence that it enhances fetal lung maturity profiles in anticipation of a delivery between 34 and 37 weeks in order to reduce the risk of respiratory distress syndrome and NICU admission. But is there really evidence to support that? Well, Kamath-Rayne and their group in obstetrics and gynecology tried to answer this question, and it was just published in May of 2012. They examined 362 neonates born after 34 weeks and after fetal lung maturity testing. They had 102 that were immature on the amnio that were treated with steroids and then delivered within a week after the treatment. They had 76 that were immature that were managed expectantly and delivered at a later gestational age. And finally, they had 184 that were mature and delivered in an expeditious fashion. This next slide shows their results. On the left column are the mature amnio results. That is to say, this is the group that had a mature result and were delivered. And you can see they delivered at an average gestational age of 37 weeks. In the middle column were the expectantly managed group. Immature amnio, allowed to progress in pregnancy a little bit and then delivered. And their average gestational age was the greatest at 38.2 weeks. And finally, the right-hand column had the immature amnio group that were given steroids and delivered shortly thereafter. Their average gestational age was 36.4 weeks. What were the outcomes? The next row is adverse respiratory outcome. And what you can see is the mature amnio group had a 3.3% risk of respiratory problems. The expectant managed group had the 1.3% of adverse respiratory outcomes. And surprisingly, despite steroids, the immature but steroid group had the highest 9.8% risk of adverse respiratory outcome. This trend was mimicked in terms of overall adverse neonatal outcome: 14% mature amnio, 18% expectant management, and look at this, 26.5% in the immature amnio but got steroids group. Their conclusion, and I agree, is that antenatal corticosteroids after immature amnio did not reduce respiratory morbidity in neonates born after 34 weeks. At the present time, there's insufficient evidence to recommend steroids, even when anticipating a late preterm birth. This brings us to our conclusions, but before we review this slide, I think it's appropriate to go back to the polling questions that you so kindly answered at the beginning of the talk to revisit how you would answer them now that you've heard the speech. Let's go back to the first question. Is it appropriate or desirable to dose the second dose of steroids in 12 hours instead of 24 hours when preterm delivery is felt to be likely prior to 24 hours? Before the webinar, most of you said yes. Now 100% of you are saying no, which is the correct answer. Let's go on to question number 2. Are antenatal steroids beneficial prior to 24 weeks? The answer choices are yes, no, I don't know. Before, many of you had said yes, but many of you had said no. Now we have 100% yes, and that is the correct answer. The final question. And I think most of you answered this correct to begin with. Should antenatal steroids be repeated every 2 weeks until 34 weeks in pregnancies remaining at ongoing risk for preterm birth? Before, we had some split between yes and no. Now all of you are answering no, and that is the correct answer. So, in conclusion, antenatal corticosteroids have been shown to decrease neonatal morbidity and mortality. A single course is recommended for pregnant women between 24 and 34 weeks who are at risk for preterm delivery within the next 7 days. A single rescue course of antenatal steroids may be considered if the antecedent treatment was given at least 2 weeks prior, the gestational age is less than 33 weeks, and the woman is judged to be likely to deliver within the next week. And finally, there is no clear benefit to steroids after 34 weeks at this time. Well, I very much appreciate your attention. At this point, we'll entertain any questions that you have that you can type out. Let me click on the first question. The question is this: if you're giving a rescue dose, should you administer 1 shot or 2? That's a great question. Some clinicians, because of the data on repetitive dosing being harmful, think that 1 shot is better to give than 2. The answer is that's not a well-studied situation. The original studies that showed the benefit of steroids showed that the course that showed benefit was 2 shots of betamethasone or 4 shots of dexamethasone. So, when giving a rescue course, you should go ahead and give the full course, which consists of 2 shots. I have another question. If a patient receives a rescue dose and goes on to have a recurrent risk, is it okay to give a 3rd dose or a 2nd rescue dose? I know this is tempting, especially in a very premature baby, because the Wapner trial, which was considered authoritative, didn't demonstrate harm until there were 4 doses. But there is suggestion from other data, including basic science data, that the more exposed a neonate is to steroids, the greater the risk of those complications that I mentioned. So I would corroborate ACOG's recommendation that the dosing should still be the initial dose and at the most a rescue course. Here's a question. When dates are uncertain, how do you determine when to hold steroids? I think that's a great question. When dates are uncertain, which sometimes happen, but fortunately not frequently, because now we live in an age where most pregnant women get ultrasound and early ultrasound, but of course we have unregistered patients who don't get ultrasounds. If I have a viable gestational weight and obstetrically I'm considering the pregnancy viable, and for me that ranges between 450 to 500 grams, that would determine my threshold for viability, and I would give steroids at that time. I think the other end of the spectrum is a little harder to answer, in the sense that, is somebody 33 weeks, is somebody 35 weeks? At the end of the day, if you get that guess wrong, it's not so bad, because the neonatal risk of prematurity at that late gestational age are not very significant. And on the other hand, if you decide to give steroids and they're beyond 34 weeks, you haven't done any harm. Well, I think that's all the questions. I want to thank you again for signing into this webinar, and I hope you have a great day.